Good afternoon, everyone, and welcome to today's important and very timely webinar and information session around shaping the future of healthcare, how corporate South Africa can help solve universal healthcare access. My name is Mandy Wiener. I'll be the facilitator today, joined by my extremely wise and insightful panel. And it's a pleasure to have you join us here in the room, and for those of you who are joining us online too, for what promises to be a thought-provoking and action-orientated discussion. Now, across South Africa and globally, we know that universal access to quality healthcare remains a pressing issue. And very often we are inclined to leave it to government. Government has much of the responsibility. But it is clear that business has got a critical role to play in enabling better healthcare outcomes for all. So today, we'll be exploring how corporate South Africa can move beyond just compliance and philanthropy and become a real partner when it comes to universal healthcare. So we'll take this opportunity to unpack the opportunities, the responsibilities, and the tangible strategies for private sector to drive systemic change. So I'd like to introduce you to our panel today. We're going to be exploring the big questions at the heart of this discussion. John Judson is the CEO of Kaelo, our hosts for today. Roy Murray is the CEO of Dis-Chem, and if you somehow managed to miss it, Better Awards launched yesterday. We'll be talking about that, don't you worry, if you got your personalized video. Ilse Roux is the Corporate Affairs Executive at Bidvest, and Melanie De Costa is the Director of Strategy and Health Policy at Netcare. We'll be having this conversation for around an hour and a half or so, but we will take questions from the audience. So if you have your questions ready to go, I will give you an opportunity for that. And if you're watching online, you can also send through questions which will come through to me that I can pose to the panel. But I think first, John, as a scene setter, to explain to everyone why we are here today, why we're having this conversation. Give us a broad overview of where we are when it comes to NHI, to implementation, legal challenges, and what your position at Kaelo, what your position is on NHI.
Yeah, thanks Mandy, and thanks for everyone for joining online and in person. Kaelo's always been completely behind the principles of universal access to care and NHI. And what we found is when the Act came in place, that it didn't deliver on what it was expecting to deliver on, and that's a function of resourcing infrastructure, and we don't have to go down that road too deeply. So we believe in the principles, but it hasn't delivered on its promise, and so in the period subsequent to the Act coming into place, we've seen a significant demand for private healthcare to solve the problem of people who don't have cover. And so we have the products in place, and we believe that corporate South Africa could play a role in unlocking this in this care. And so the instruments exist. It's sustainable. The policy that was supposed to solve this for the country just hasn't landed, and we think the private sector can play a role in effectively providing universal access through that.
And I'm going to do a quick whip around of all of you just to get a sense of what your positions are when it comes to NHI, just so that we can get a base position, really. Roy, does Dis-Chem have a house view on NHI?
Yeah, so Mandy, I think the important thing is actually to look at like healthcare delivery in its totality outside of NHI, right? So I mean, if you have a look at the healthcare landscape in South Africa, it's extremely positioned to be disruptable, and I think I described that because of the intention of NHI and what it's trying to achieve, but the practical implications of what needs to happen, right? So if you look at the healthcare industry in South Africa, it's probably, from a healthcare cost perspective, there's probably a 47% contribution from a private sector, 45% contribution from the public sector. Public sector growing slower than the private sector, where we know it's illogical, right? Because we know that there's more demand, but there's just the sign of the infrastructure issues that exist there. And then the public sector growing at 9%, not consuming new lives, that's just a function of medical inflation playing out into how people fund healthcare. And then you see this out-of-pocket space, which is actually the most interesting piece, and that is people who can't afford to participate in the private sector, but now not being serviced by the public sector and touching the private sector at what is the most expensive healthcare delivery rates. That's growing at like 11, 12%. Very similar growth rates to elements like medical insurance, which are, other ways of accessing healthcare. So, I mean, when you look at that picture as a provider and as someone who's looking to build an integrated healthcare ecosystem, like it screams disruption, right? And if you think about how NHR plays into that, it really needs to kind of take the benefit of public and private initiatives and deliver it in a way that's effective and reduces cost and increases access. We see it from a provider perspective in some pockets of the country where we're partnering with the state to deliver certain services. But that principle and philosophy is not necessarily ingrained in the concept in its entirety. So to John's point, I mean, the reason it exists is right. The form that it's coming in pieces makes a lot of sense, but it's moving very slowly because of the adoption around kind of public and private sector kind of infrastructure supporting one another.
Mel, as Netcare, do you have a position on whether NHI in its current form can work or what would require it to work?
Yeah, so thanks for the question. I'm actually going to answer the question more from a hospital sector perspective, having looked at this and been at the table since 2013. So firstly, just to state, I think we're all in this room, living in this country, loving our country and understanding to have the best version of our country. We want a healthy country. So what does it take to achieve that? We currently have a public sector that is on its knees. And we have a private sector that I think everyone will admit that has become increasingly more unaffordable. So that is a function of some flawed, half-pregnant legislation that was put in place and never completed. It wasn't completed at the altar of this vision of an NHI. And as a result of that, you have two systems that are now flawed. The NHI seeks to solve that, and yet it doesn't. And for that reason, it is irrational. It's irrational because you can't raise the funding for it. It's irrational because it doesn't solve for either the problems in the public sector or the private sector. So we want it solved, but a single fund NHI is not what's going to solve for it. And hence you currently find yourself in a situation where you've got 8 litigants in a court case. You've got a court case that just at a start could take 2 to 3 years just to be heard. So we have no choice. We have to solve this today. We can't afford to leave this in the hands of the government, and we certainly can't afford to wait 10 to 15 years to solve this, because this is what's brought us to this situation at the moment, because we've been waiting since 2007 for this NHI, and hence the outcome that we currently sit with.
Ilse, you're looking at this from a different perspective. You're sitting here not necessarily from within the medical sphere, but as the second largest employer in this country. Looking at it from the outside in and seeing what's unfolding, do you have a position on the NHI and whether it can function?
Well, Mandy, it's as you rightly point out, we a citizen here, a corporate. From our perspective, is we employ over 100,000 people here in South Africa. Many of them are basic income employees. And the pressure and the need of these employees to access a functioning, basic preventative care is what is critical. We deliver our business through people. If the people aren't healthy, if they're not at work, if they're not able to function, we don't deliver our business. So we have to find a way to help our own people be able to access healthcare whichever way.
And today we're looking at the solution and how that could be possible. John, given that only 16% of South Africans belong to a medical scheme, what are some of the biggest barriers to actually getting and accessing quality healthcare for the majority of the population? Tell me about the resource constraints.
I mean, there's so many good examples, excuse me, but an easy workable example that I was chatting to Roy about earlier is in the public sector, for someone to see a GP and get meds. And first of all, there's 5 times more people that are expecting to see a GP in the public sector than the private sector. So the ratio is 5 times worse off in the public sector. So that'll give you a sense of it. But how it plays out for someone in their everyday lives is it requires about 286 minutes to see a GP and about 116 minutes to get your meds. So you're in for like 6 to 7 hours as a person who's working that wants to consume healthcare in the public sector. And that's not even talking about provincial state hospitals. That's just going to a clinic which should absorb a lot of load. And so that is easily solved by the public sector and about big on the private sector. And it should ultimately take load off the state and just ease the burden. But that's, I think resourcing infrastructure, I know Mel has good examples of infrastructure constraints. So I don't think the private sector can solve infrastructure and resourcing for the state, but it can take load off the state. And examples like I just gave there's many of them. There's 23,000 citizens for every one dentist in the public sector. So you can just see what that does to other forms of care that there are.
So advocates of the NHI, people that do support it, there are people that do support it. If you look at those numbers, right, so 16% of the population relies on private medical care, which means 84% of the population relies on public health care. The argument is, surely it can just absorb another 16%. Is that even feasible in reality, Mel?
Lies, damn lies, and statistics. I love it. I love it. So I think it's a little bit more complicated than that. The expenditure on health. So firstly, yes, the public sector is the bedrock of healthcare in the country. It is grossly under-resourced. The waiting list, the queues, the shortages of doctors and nurses. It's actually heart-wrenching if you really go into the detail. If you just look at the lack of access in the public sector, of which I won't go into the detail. So no, it's not just a function of throwing more people at the problem. It really isn't. Close on half of the resources in terms of rand value is spent in the private sector, and it's not a function of the fact that there's an overutilization in the private sector. If you look at international benchmarks, the numbers of doctors and nurses in our country is really low by international standards. If you want to solve the problem, you've got to increase the resources in our country. Part of the solution, why is it that private sector can't train doctors? Why is it that we've got all of these rules and regulations on the number of nurses that we can put into the system? 1 in every 2 doctors coming out of India, coming out of Brazil, are from the private sector. We're not allowed to train in South Africa for whatever reason. Highly regulated. But back to your question, no, it's not just a function of absorbing those in the private sector, not at all.
So I like to speak about, and this is quite ironic, the accident and the ambulance. We know that we've got these problems. How do we solve for them? What is the ambulance? What is the solution to them? So let's look at that solution now. Ilse, from corporate South Africa's perspective, and I realize you are not speaking on behalf of the entire of corporate South Africa, but does corporate South Africa want to solve this problem? Are they standing ready to get involved, or is this something that corporate South Africa feels isn't necessarily in its wheelhouse?
Sure, Mandy, you're correct. I can definitely not speak for my fellow private sector corporates, but at Bidvest, absolutely. For us, as I said earlier, we have to have healthy and safe people to deliver our business. But we also realize that we can't do it on our own. We do own 250 businesses, but none of them are doctors and none of them are hospitals or anything like that. So our firm view is that we have to collaborate across the value chain and the entire ecosystem. But it has to be in a commercially sensible manner, because otherwise you're just not going to have a sustainable solution. Because imagine that if you introduce something this year, next year, the budget, you can't do that. So you have to be absolutely convinced that the collaboration, the buy-in from all the parties are real, are sustainable. And therefore, it is not just the philanthropic, the social, the people good feeling considerations. You have to say, is there a commercial model in doing that. And, we've gone a long way down the road with Kaelo and finding a solution for our 70,000 basic income earners. And we think we've done so. But it is critically important that we understand that it has to be commercially viable.
Roy, why is the solution not to improve public health care, to put resources into better funding public health care doctors, into donations and just philanthropic outreach? We know Dis-Chem obviously does a huge amount with the Dis-Chem Foundation. Is that an approach to take where you just help them up rather than move people to the private sector?
So, I mean, if I'm honest, I think you have to talk to the efficiency of the investment, right? I mean, ultimately you can, but can you extract the same amount of return from an investment like that as opposed to simplistically trying to move volumes from the public sector or volumes that are reliant on the public sector into the private sector? I mean, if you think about the most important stakeholder in that equation, the most important stakeholder is the consumer, someone who's going to ultimately receive healthcare. And often the private sector is viewed as, yes, they're shareholders and we have to generate a return. But the important thing about the private sector is that it always gets looked at through the lens of competition. If you're not good at what you're doing, that filters into the service that a consumer receives. And why should healthcare be any different, right? So you can go that road, and I'm not saying that road wouldn't be supportive, but it certainly wouldn't systemically and sustainably solve the issue that exists in South Africa. I mean, Mel described it really appropriately, but I mean, you simply have a private sector that has capacity, a private sector that can deliver healthcare. I mean, I've got my own versions on whether the private sector can improve the efficiency of healthcare delivery in the way that the regulations are written, and even in the way that the service providers have adopted technology, for example. But we are certainly positioned to be able to do that and solve healthcare for more and more South Africans, which ultimately is a basic human right. And if we do solve it, the consequences of solving it for a growing economy and all of the other benefits, are natural, they're obvious, right?
So, John, to pick up on that, why do you believe that is not the solution to lift the public healthcare system as the private sector rises? And what do you think would be the solution, the better alternative?
I think further to Roy's point, the consumer is driving the demand. So whether it's the employee value proposition that corporates are putting in place to attract the right staff or keep them, ultimately they're doing it because there's an individual that's looking for healthcare that they can't solve outside of it. And so it can't be solved through out-of-pocket spend because some of these healthcare incidents are way beyond someone's earning potential or free cash flow that they sit on. I mean, a hospital event could be north of R1 million. And so people need to solve this through some form of insurance mechanism, which does exist. And so corporates are solving it to lift the EVP for commercial good, as Roy said, but there is downstream impact in taking load off the states. And I think that, and I mean, Bidvest is a great example because they've done it across many different business market categories and wide geographies. And they've solved it not only as Bidvest, but they've solved it as individually high-performing business units. I think you said 250. You've got these basically smaller corporates across wide geographies solving this for their own commercial outcomes because they need to solve it for their people, and ultimately that has downstream impact on the state. I think that and through that mechanism of corporate purchasing, it actually becomes significantly more affordable for people. So to try and do that out of pockets, as I mentioned, impossible. But if you were to buy insurance as an individual, the price point would be beyond the reach of most persons' payroll. So corporates provide an accessible form of this cover almost immediately to people.
Mandy, can I to jump in here? What was really important for us in this consideration is our people. There's few of them that work on our sites, but they mostly report to corporations around South Africa, their sites, remote across South Africa. So we had to find a solution that says any one of those people can, within quick distance, find primary health care, find a sister, find someone that can help them. So we had to be sure that the service provider or the offering is equitable and achievable, practically achievable. So that was a very big consideration for us to be able to do that. So then you do use your scale to negotiate that, to make it more affordable, to tip the scales, to really bring those people into the equation.
So John, if I understand it correctly, and to break this down into very specific terms, you're saying that the solution is to offer every employed South African private healthcare. Is that correct?
Yes, and a very good example of that is Brazil. So Brazil implemented NHR a long time before us, and they have 52 million people on private healthcare, largely funded through corporate mechanisms. But the insurance structures exist. You can buy them directly in Brazil, as you can here, and you can buy them through corporates. But corporates unlock that value chain. So 25% of Brazil are covered on private healthcare, and you can imagine what that did to their state system. So it's a natural market force, we believe, that is going to play out.
So, Mandy, what it does is it decants the public system. So you only have a set amount of money and a lot of people dependent on public health. The extent to which you can decant the public system so it can breathe and that public rand can go further for the most vulnerable, that's what you're doing. So we have a lot of people that are in the informal sector or unemployed, and we're saying the extent to which corporate can come in, step in for those that are employed, and enable the government to look after the most vulnerable.
Can the private sector sustain that influx of patients?
In terms of capacity is the question. So in terms of resourcing, from a number of doctors, there's infinitely more doctors sitting in the private sector, unfortunately, than the public sector. And I say unfortunate because the demand is really sitting in the public sector. So yes, the resourcing is there in the private sector. From a hospital perspective, you'd probably hit ceiling sooner than you would in the primary care space. We think that in the hospital sector, and I see Inside Actuary sitting in the room. He has a punt for Inside Actuaries. They did some work for us just before the Presidential Health Summit in 2018. And at the time, based on the existing capacity in the market, we felt that we could absorb just short of 8 million additional people into the hospital system itself. And that was before considering new technologies and innovations. And something we can discuss in a little while, that means improved efficiencies. So yes, there is capacity in the market.
So Roy, looking at the numbers then, in terms of how many people in South Africa are covered with medical schemes or medical insurance, and how many could potentially be going forward, is this a rational business case?
Yeah, I mean, absolutely. I mean, so I guess it depends on how you cut the opportunity. But I think one of the things that is sometimes looked over is that if there is an opportunity, that is one thing the private sector is good at doing, is investing behind an opportunity, right? So I think, I mean, Mel and John have both made the point, but specifically in the private sector, capacity already exists. I believe that there's a lot more innovation that will come into health delivery, and if regulation forms and starts to, I suppose, use the appropriate providers to the appropriate delivery of healthcare in the appropriate setting, you can extract a lot more efficiencies. I think the way that the scheme market has been structured in South Africa, it doesn't solve for access, it solves for choice. So you can, for example, go and get access to quality healthcare, but in an efficient way based on the provider that's giving you that. Now, in the medical insurance space, that needs to be channeled because of the price point that you need to arrive at. And the private sector can use infrastructure and support investment in infrastructure to do that, even when we kind of tap out the ceiling on capacity. So, I mean, Mel is right. In the primary care world, it's very different. The number would be north of the 8 million in terms of what we can afford. If I think about kind of the number of pharmacies that exist, if I think about how much clinic capacity we have, and that's really, the commercial kind of play that the ecosystem that we're investing in supports, right? I guess, from our perspective, we see ourselves, we're an employer of 20,000 people, we're a provider, we're effectively an insurer, so like that is the opportunity that we're seeing.
So let's look at a practical example, right? For people that are currently beneficiaries or dependent on private healthcare, what does this hypothetical scenario look like? Does it mean I'm going to wait longer to potentially get approval for a procedure? Will I be guaranteed of getting a bed? How does it impact practically, and what would the model look like?
I love these first world problems.
Hashtag, am I going to get my private room at the Linksfield?
Yes, it means that you might wait a little bit longer, but what a lovely problem to have. There's a consequence to everything, and I guess you're weighing up on how to solve a systemic issue in the best fashion that you can. What it might mean in terms of some consequence in terms of waiting lists, yes, there might be some of that, but I think all in all, the best alternative we can have, and just to share with you that we have put these proposals forward to the presidency in terms of NHI alternatives. They've been, so what happened before Hospital Association launched litigation last year, we thought one lost salvo at some attempted resolution because the discussion was just NHI. So we put out an alternative, and stemming from that alternative, which, by the way, was not our brainchild, it was really putting back to the ANC the reform pathway that they were under, that they had started. And we were just saying, complete your own pathway, because it was a good pathway. It was very well formulated. But as we did that, then there were 3 or so other proposals that were tabled, and all of them came out with the same situation, which is the only way you can solve this is private and public coming together, and we solve this as a country. It cannot just be a regulator seeking to solve this on their own. So yes, the view is that you can only solve this if private and public come together, and there will always be some fallout somewhere.
Yeah. Ilse, it sounds expensive for corporate South Africa. It means that you're partially going to be, funding this, obviously, because it means offering every single employee private healthcare. Is this something that we're going to need an evangelical mission to do, or is it in the interests of employers to be doing this?
I suppose, Mandy, Bidvest is a decentralized group. So what we know about ourselves is if that we convince ourselves, then it's a good idea. Then it's all okay. But we're our own toughest competitors. So it has taken a lot of education, conversations with a buy-in top down. Because ultimately, we're not the type of group that says you will do that to 250 businesses. It is understanding and educating people to know what the challenges are, listening to 70,000 low-income earners on what their needs are, and then saying, let's put it together. And the critical part was we needed to make this compulsory. Because by making it compulsory, you lower the price point, which makes it more sustainable for the insurance provider, it makes it sustainable for us. And ultimately, it is not just about putting the product in play today, but making sure that the rate increases, the premium increases into the future is affordable for these people at these levels. So it's, we've been on this journey for 2 years. Nadine will know better, but we've got about 15,000 people on the program so far. Our aim is 25,000 people. But it's a tightrope to walk. There has to be a commercial reason. So we have gone, on some businesses decided to fund it 100% themselves. Some of our businesses thought people need to pay a little bit for it to realize the value or recognize the value of this product in their hands. So it's a bit of a hybrid, but the principle is it's compulsory, which means we protect our people even if they don't know it yet.
Yeah.
They're going to experience it. And we have lovely stories of people that just recently got onboarded on this product and had an emergency. And it changed their lives.
Sure.
And saved their lives. Because in our frame of mind, Many of our employees are female, single-parent households, depend on them. And if that individual falls ill or God forbid, dies, you have a very big problem. So it's not just solving for our employees, it's solving for the village around our employees, around our businesses on a daily basis.
So let's pick up on affordability, John, because that's often what it comes down to. We know that medical scheme membership is reducing as it's becoming more and more unaffordable. Most taxpayers in lower income brackets. So how do you make this affordable?
Yeah, Bidvest is a great example again of that. And affordability is not only a function of scale, because 70,000 you can make a plan for, you can sink some overheads. I don't have to go into the details, but the real opportunity is if they decide on collectively to go ahead with this, we do have the ability, because of the way that we are structured as Kaelo, as a vertically integrated health management organization, where we have the administrator, we've got the insurance risk-taking business, and we've got the network provision. We are able to consider every business that is in the 250 businesses that make up Bidvest as its own entity and onboard them as effectively compulsory, which then helps with anti-selection. And it's not just the scale by volume, it's the anti-selection that we're able to eradicate. So even a small business that we deal with the brokers on the call and intermediaries is that it could be 100 man, but if we can make that compulsory, and we don't mean it compulsory on a point load, because we also understand that taking on an insurance product onto your payroll on a 2-3% loading is significant. So that point load, we remove the point load by gliding it across over time, which makes it affordable for the employer and the employees. And what that means is that the entire organization is effectively compulsory over an extended period, whereas the historic definition of compulsory would be everyone on cover today. But because it's not a function of purchasing at scale, it's a function of reducing anti-selection, we can able to do that over time because we own the vertically integrated stack. So that's how we go about it, and it works.
Are there any regulatory barriers to this happening?
The firm regulation has been pending for over a decade, perhaps more, depends on what lens you see it through. Every piece of evidence shows that the current structure works. And so we expect it to formalize. The Financial Sector Conduct Authority has jurisdiction over a lot of what we do in terms of production data, and it goes into their OSTI. And so we know that it's producing a good result because there's no member pushback, there's no ombudsman fallout. And so it's sustainable at a member level, it's sustainable on a risk basis because the regulator has an eye on risk, it's sustainable on a market conduct basis. And so all of that data is flowing into the different regulators. And I think that the Council of Medical Scheme has been grappling with this problem as to how do you solve for this market without destabilizing the medical scheme base that it sits with. And I think that the work that was done by the four streams at the CMS, which were a product stream, an intermediary stream, a legal stream, and a commercial stream, ultimately established that the way it currently works does actually solve the problem, and potentially would leave the medical scheme sector intact. So the short is that if you have the ability to afford a medical scheme, take one. But if you can't, then what are you left with? And so the current regulatory environment does provide for this and make it sustainable.
Roy, when you look at the purchase power of corporates and the ability of insurers to use that vertical stack of insurance instruments to provide an affordable set of benefits that are sustainable, what are the optimal benefit designs when considering this market demand and health outcomes?
I mean, it's an interesting question. I think in many instances, I don't think we have products that have optimal benefit design as yet, right? I think just as a function of how we've evolved from what was scheme or nothing to now a scheme and a different form of product that sits under a different regulatory lens. To me, part of the innovation, and specifically when you provider-led and you have ambitions to kind of own the integrated healthcare ecosystem, lies in the funding structures and the inclusion of benefits within certain products, right? So to me, if I think about the future of the microcosm that is Dis-Chem, I see us evolving the way we think about benefit design in funding products that allows it to be of relevance to more and more South Africans, which indirectly means there's flexibility of price point, right? I mean, it's just obvious, and I think it's one of the most important things. Like corporate, and again, we sit in this world where we are a provider, we are a retailer, we've invested in the health of our own staff, we also own the insurer. And what you do get from a corporate perspective is what John described, is the ability to unlock significant value for the individual. And once you lock that significant value, you, as a function of the way that in our world we solve for something like a reward, you put value back into the pocket of the individual or the employee to then go and invest for members of their family, right? So you're using other funding mechanisms within the private sector to effectively not increase the spend of that individual's wallet, but open up value in healthcare delivery. So that is, to me, the biggest, in my mind, the biggest opportunity in the way that we've certainly designed our business to try and take commercial advantage, but to try and deliver healthcare access to more South Africans.
I just wanted to add, and we've seen that in our take-up through our rollout, that this reward system actually pushes money back, which means the employee can add another dependent or another child. And the pool just gets bigger and bigger and bigger. And I think the team gave us the stats the other day. We are sitting at over 30% of our own employees have put dependents on. And that is 100% out of their own pocket, which they didn't do last month. But they see the value and the impact on their wallet on a daily basis is protected to some extent.
So I have to say, the cynical journalist in me, John, is going, oh, but you're just growing your customer base as the private sector by following this model. Is that a fair perspective to take?
It is. I mean, I think it would be reckless of me to say it's not. I mean, that we do it to get a commercial outcome, but we think we can do well by doing good. We can really impact this market. And I just want to touch, if I may just take a step back onto Ilse's point and to what Roy was saying. We think the benefit design can improve significantly, and as affordability becomes more, we stretch that affordability open, and technology plays a role in terms of what's in there. But what we're finding in our data is that people gravitate to the health insurance product that looks most like a medical scheme. That people want the top kind of the most like laundry list of items. And in fact, what you notice in lots of employers, and I'm using Dis-Chem as an employer here in Bidvest, is that certain of the more entry-level health insurance products actually produce as good a health outcome and an employee value proposition and make it more affordable for the corporate and for the employee to put their dependents on. So you get this cascading impact of a much tighter benefit basket that makes it more affordable, but it opens up access to care for many more people. So I think that benefit design, although it can be better, it also needs to be considered around the reference point that the consumer is coming from. So if I have no cover whatsoever, a product with 5 chronics, 8 GP visits, and hospital cover is a huge step forward, especially if I can put my dependents on that, as opposed to the top health insurance product and none of my dependents on it. So that's how we're seeing a very big trend moving towards more efficient benefit designs, but more people on cover. And it produces the return at a corporate level and at an employee level.
Sorry to interrupt again. That was exactly the outcome. You know, we started the journey thinking, oh, people are going to ask for specialist cover and you know, top end type of stuff. And our people told us it's the basic day to day. It's the GP, it's the medicine, please just help us with that.
Is that what you're seeing, Mel? Is that
You were
when it
asking
comes to
about
healthcare?
you were asking about the stack.
Yeah.
So when we started building this as an industry as alternate solutions to the NHI, step number one is the primary healthcare solution, and then when you start speaking about what might the cost be to the employer, the average contribution for average medical scheme contribution, like literally just one divided by the other, average is low 2000s. But if you're looking at a primary healthcare product, I don't know, maybe you want to give figures so that I don't mislead anyone, but you're starting to talk 10% of those type of figures, right? So that would be the burden on the prior. And prevention is better than cure. So if you can just solve for that, get people back to work, have mothers confident that their children can also be looked after, that's a really good start. Then after that, maybe you want to talk about the trauma cover, so trauma and accidents. And then once again, you're talking a fraction of the medical scheme contribution if you're starting just at those two levels.
Yeah.
So I'm interested if we are seeing then a higher dependence on private healthcare, which means that you need to, in your hospitals, cater for more and more people. Are you not spawning competition for yourself? Because other people will go, oh, there's lots of opportunity there now.
Well, this market hasn't really taken off at this stage. So we're not at that point. And maybe, you can update numbers, but in terms of the trauma products, 1.5 million lives, plus minus, are on these products. And I think that's what we're saying. You've got 2.3 million people that are formally employed above the 30,000 Rand a month. Those are the type of target markets you want to hit. And then you've got another 10 million sitting in informal employment that don't have any level of cover. So I think this is just about giving them, the South Africans, some level of cover.
Yeah.
And just to close the circle on rewards, you've obviously at Dis-Chem just launched Better Rewards. How do you feel that is positioned towards ultimately what you're trying to achieve, and why is it so important?
Yeah, so I guess it depends on the lens at which you look through rewards. So rewards historically in retail have always been and generally it's no coincidence that people have called it loyalty, right? It's like a card you carry, and if I had to ask anyone in this room, you have multiple cards, maybe some physical, some digital, and it actually doesn't drive a specific behavior. It's almost you get asked at point of sale, you take it out, you get a benefit which, at some point in time surprises you. Because you get something for free, or you can use your points to pay for something. But when we were thinking about medical insurance, and medical insurance in the way that we had kind of designed the ecosystem, we had always felt that because of the demand side, there was going to be a consumer reaction, right? So we sit here with brokers, and there's a role to play in terms of selling to corporates, but ultimately the consumer is going to vote with the consumer money, right? That's one thing that we understand as retailers. And there was a huge opportunity for us to put this into the market from a retail perspective. The one thing we needed to do, which is no dissimilar from some of the principles we've discussed, is how do we find funding, and really find funding, right? So, as a retailer, we have pockets of funding that are not traditional. So, if you think about how we built Better Rewards, there's an element of funding that comes into the reward program that is invested in healthcare that comes from a whole range of suppliers that sit on our shelf. That is not a traditional source of funding that healthcare service providers have. So we incubated this concept of extra rewards at the time with this very, very basic mission that said, if there was a price point, let's call it 600 Rand for medical insurance, how do we open 600 Rand's worth of value in mass market South Africa's wallet so that they can repurpose that value into healthcare? And that kind of became the mission. And what we saw kind of 2 years into that was, I suppose, all the appropriate commercial metrics, but we actually saw that people weren't spending more. They were just redirecting their spend into an environment that allowed them to unlock value, and in doing that, they were able to pay for the healthcare product. The next obvious question for us was, we did this to a cohort of 300,000 people. How do we go and do this to 10 million people, right? And that's where the concept of Better Rewards came in. So, that base discount is now much higher than our normal 1.5% that we are giving back. It's 10%, and then there's specific call to actions that are aligned with what we're trying to do as a healthcare provider. So a pharmacy boost is really around preventative health. You come to our pharmacy, you open up another 5% in the front shops, in your front shop purchases. you invest in healthcare, like medical insurance or life, you open up another 10%. So now these discounts start to become meaningful, and they are immediate at point of sale. So 25, 20, 30%, 40% at point of sale on things that you use and consume every single month.
How many people go into discount and want to get one thing and walk out with a trolley?
Yeah.
Like,
Yep.
hands up, everyone.
Which ironically is why the campaign was built around the length of the till slip, which should have a negative connotation, but hopefully we've spun it as a positive one. But in any event, I guess the point was that it became a mechanism for us in the way that we found to build our ecosystem to really open up value from untraditional pockets of funding and allow a consumer to invest in their healthcare. Because primary healthcare investments, I mean, things that may not naturally seem obvious to this audience, like dentures, for example, and the ability to kind of just, there's so many things that are not naturally concerns for us that mass market for South Africa face. I mean, John touched on it. Like, those things are so important. They change the lives of mass market South Africa. And that's really how we did it. That's also the reason we had a partnership with Capitec. They give you incredible digital access to mass market South Africa. And I mean, we almost see, or the way I see it is, you can sell healthcare, complex, hard for people to understand. You can sell rewards that give you access to healthcare much, much easier.
Yeah.
And that's really the sense of how we designed our reward program.
Ilse, do you find that people are seeing you as a more appealing employer because of this? Like, is word hitting the street? Do you think people are more inclined to work for an employer that offers this benefit?
Yeah, Mandy, I think it is definitely starting to get recognized across our employee base. That, it's not just about, many corporates talk about we care about our people, but talking and doing
How the hell
are
should we believe
two
you?
different things. And we're very, very pedantic about what we say we have to do. We have to live by what we say. So I think it really has made a big difference in our employee base. It is not always within our control because we do have lots of sort of contractual termed people. And that's why we are not just engaging in our employee base, but we are engaging at sector, at union, at bargaining council levels. Because we are talking here about job grades that are very, very price sensitive in the South African market. So, we just believe that you walk the talk, and that is going to ultimately benefit everyone.
So let's talk about sustainability before I open up for questions. And if you have some questions, start getting them ready. So John, what does sustainable value-based care actually mean in the South African context? And can it be achieved?
Absolutely can be achieved, and we've got very good track record of doing it. And I think it's through traditional models like network and managed care processes and risk management, how you build the product, how you price it, of course, actually. But I think what's very exciting about this is consumers' desire for healthcare is a willingness to follow a path of consuming healthcare. And I think further to Roy's point is you can't swim upstream in any industry. I don't think you just have a natural attraction to what people want and do. And in healthcare, that's very important that you leverage the natural behavior of people or use like a rewards program which to shape behavior. So the way people consume healthcare in our insurance products is very different to the way they consume healthcare in a medical scheme, for example. So they're using the right care at the right time. They're passing information on between providers. And those things that used to fragment healthcare consumption no longer do, which actually fundamentally changes the risk profile of that group and drops price. And so that tension triangle between quality, access, and affordability, typically if you push up access, you damage affordability. That tension can be held in place through health insurance. And because of the opportunity to work with network providers like Netcare and Discam and the other providers on our platform, but also in how reward starts to shape behavior. So rewards doesn't only give you the funding to do it, it also starts to shape your behavior that you're using and you're consuming healthcare in the correct way, which helps drive sustainability. So it's a new way of thinking in the South African context, but well tested in other markets. I do think, though, that the relationship between what we've created in the insurance product and the reward structure is quite unique. And just to touch on Roy's point there, the natural way that people go about consuming the brands on the rewards platform generates the return. So it's a self-perpetuating cycle where in healthcare you sometimes have to force people to do something to suit the risk need. This kind of takes its own path because of the combination of accessible healthcare and rewards funding helps shape behavior. So therein lies the sustainability, I think, alongside traditional models of managed care.
Mel, when you look at future-proofing, sustainability, future directions as well, technology and data are going to be big factors as well. How do you see that evolving, improving healthcare delivery and outcomes and being able to increase capacity as well in the healthcare sector?
Yeah, I think that we're at the cusp of something very unique in the healthcare space, and I think it's early days. I think that we're at the confluence of something very unique. You know, we've only seen the evolution of genomics and AI play out over the last few years. So anyone that is digitized and has data, you have such an opportunity for fundamental improvements in efficiencies. You know, in healthcare, any variability is called inefficiency. So the extent to which you can, even in any form of clinical pathway, standardize and remove inefficiency, you really start releasing capacity. So already we have seen, 10 years ago, a hip, the length of stay was like 12 or 13. And you've seen such a contraction in these lengths of stay. Hips and knees, you start...
Orthopedic surgeons, paddle players, that's why.
You're mobilizing people within a couple of hours. It's just absolutely wild. You would never have considered this in the past. So there are fundamental changes ahead for us. And I think that it will really change healthcare. You know, Google is busy playing around with 200 million proteins, and now we're starting to talk about individual cancer vaccines. Let's just say the future is not like the past. I think we're in for something fundamentally different going forward.
My last question is about gap cover. I think it's important to touch on that. You've mentioned 16% of the population is medical aid, but medical aids don't cover everything. Shortfalls are costly. So Roy, I'll ask you, and then John, what does gap cover solve for in this instance, and why can't this be solved through better design of medical aid products?
I mean, I think it's an interesting question. I think it exists because of the way that the regulation shaped up. If you look at kind of gap penetration into the scheme market, the penetration in South Africa is relatively low if you benchmark against other countries globally. So I think again, like there's an education element that exists. There are incredible shortfalls that necessarily cannot be funded. I mean, John gave the example earlier, and I mean, we see it in our staff base. So it's a very useful tool for that. I do think there's an education element, and the way that we think about it from our perspective, again, is that concept of like allowing rewards almost to lead the interest in the product, and then naturally the education comes off the back of that, because everyone understands what a discount means. I mean, that is the truth, right? That is the truth. And it's just a different way to frame the opportunity to educate. So there's definitely a huge opportunity for gap in South Africa. We see it. I mean, it continues to grow, but I do think there's an education element that needs to be done to unlock its complete potential.
Ilse, is that something you're looking at as perhaps an education or an opportunity?
Yeah, Mandy, I think we've realized, I suppose, as you go down this path, you know, you have this top element that has medical insurance, and now we're addressing this bottom end. And my colleagues have been asking, but what about this missing middle? We make up names for these things. And actually what it means is it's just people that either cannot afford that medical aid or is not covered, but gap cover could solve part of that issue. So we've realized that, we can't leave it to 250 businesses to try and educate themselves on gap cover. It's just not going to work. So people in this room will be talking to our HR and our managers to make them understand why this is important. Because unfortunately, I suppose as the data shows, you only realize you're not covered when the pawpaw has already hit the fan, type of thing. So we really need to raise awareness and then, again, through scale, make it affordable and open for a wider base of our employees and their dependents.
And John, for you on gap cover, why? What does it solve for, and why can't it be offered through medical aid?
I mean, I think Roy touched on it. The medical scheme industry is in a difficult position. Average age is increasing. New member adoption is low, and so the natural result of that is benefit compression and a move to lower plan types. And so you're finding these big shortfalls happening. I mean, a very good working example, I was talking to Carrie, who heads up our gap business. There's lots of good examples. I've got one for you, Roy, in case you need orthopedic. Someone who runs 200 kilometres a month at sub 5-minute Ks or 4-minute Ks, he's going to need a knee replacement at some point. So
to look forward to, I guess.
I know a guy.
But you play paddle, right?
Talking about for orthopedics, 80,000 rand shortfalls, that's not achievable for most employed people. They just don't have that lying around, so they just go without care. So large parts of South African employed workforces who are on medical scheme just don't get care. Another example we had was, not one, by the way, this is a trending element, 30 to 40-year-old females with endometriosis, that's 115,000 rand shortfall. So a 35-year-old employed person on a medical scheme cover simply doesn't go and get that procedure done because it's so costly. And so those working examples will tell you that that there's a demand side. We've had 320 corporates in the last year ask us for quotes. It's about 100,000 principals, which is a significant when you think about in the context of the current gap cover. So there's a natural demand side for gap now because medical schemes aren't covering that shortfall, and they are too big to fund yourself. I think the nice thing about gap is that it's really once you understand like a bit of it, it's real easy to solve because 92% of all of the claims happen in two categories. So from an insurance perspective, it's easy to bundle and manage, and through partners like Netcare, we're also able to manage the costs at the end of it. I think to bring this back to the topic of the discussion, corporate South Africa have the ability to unlock the funding for this further in the way Bidvest and Dis-Chem have done for their staff, because at scale, again, it's not only because of the function of how big they are, it's also a function of making it effectively compulsory. And so I understand compulsory for medical scheme members on gap cover is a very difficult thing to achieve from a policy perspective in corporate South Africa. So we've created a mechanism that doesn't require policy change at a corporate level, but effectively allows compulsory price points, which is decline offer. That decline offer drops the price significantly. Most corporates then implement it alongside this rewards program. Effectively, then you now have gap cover that is funded for all of your medical scheme staff. And in so doing, you provide care to many people who would go without care, like that endometriosis example that I used. And I think alongside partners like Netcare, we're able to drop the price point of those procedures through technology and bed days and things like that. So, yeah, it's becoming strangely, care is becoming inaccessible because of the medical scheme benefit compression, but much more accessible because of gap cover, sophisticated insurance.
Okay, so I would like to open for questions. I think there's a microphone, so if you can put your hand up. If you are watching us on the webinar, please post your questions. They will come through to me, so I'm very happy to pose them. Just let me know who you'd like it to be posed to. By show of hands, I think we're just going to start because you're in a... You can't lift your hand, can you? You can lift your other hand. He's in a sling if you're watching online. Go ahead.
Thanks, Mandy. I'd like to address this to both Roy and John. Just listening to you describe the issues around benefit design. So we've got this situation where the medical schemes have 1.5 arms in slings or tied behind their back when it comes to their benefit design. So real restrictions on what they're able to do. You're much less encumbered by this, right? And so the medical insurance policy started out looking like medical scheme light, medical aid light, but now you're seeing completely different benefit designs come through, and it's really in response to the demand and what's affordable. So I'd just like to have a bit more from both of you on that benefit design. What does the perfect benefit design look like? And then there's a secondary aspect to that, which is how are the medical schemes going to react, or the regulator of medical schemes? If you guys are successful in, say, doubling the number of people that are covered, I mean, you're eating the lunch of the medical schemes there, right? You're going to be a big sucking sound of youngsters exiting medical schemes, taking up your policies. So how does the regulator deal with that?
I'll have a go first.
John, go first.
Go ahead.
I mean, maybe the second question first is that I think that health insurance products are starting to shape the volume at can I call it the entry-level health insurance products, and that is so far away from a medical scheme benefit design that it doesn't attract that young group out of it. And so I think that's an important part of the industry that needs to be well managed by the regulators, in that the product design solves a problem but doesn't destabilize the medical scheme industry. And I think that was I know Barry's in the room, he can give you much more insight there, but there was a pun on purpose. But, and I think so that I think is one thing, is that there's this quite a dichotomy between the two. And in terms of the design and optimal design, what we find is, and as the corporates become more informed, as intermediaries become more deeply invested in how they consult to them, is that a corporate's looking to solve the moral dilemma. So they'll look to solve the big ticket item where the big risk delta sits. So accidents will become important, and you can't fund an accident off payroll, you can't fund an accident of a lending structure, but the EVP sits with dentistry. So use the BPO sector as an example. The biggest value proposition that BPOs are looking for is dentistry and GP visits, because it's a young base that understand those benefits. But the corporate's looking for the accident product. So how you blend those two together is important. And I think that the blend of those two actually produces a good premium outcome as well from an insurance perspective, because your high-ticket, low-frequency events are easier to fund and more predictable than the other ones.
Yeah, I guess, my answer would be more through a Dis-Chem-specific lens. But, if you think about it, I agree with John. I think they're fundamentally two different markets. That's the first point. I think naturally, if I'm completely honest, medical insurance as a benefit design stack was solved to sell to a corporate base only. And what you're starting to see is, if you just took a consumer lens on it, the flexibility that you would require in benefit design changes, and it will enhance. Who's to say that you don't sell subscription-based health services through a reward program, right? I probably have contravened many regulations in saying that, but the point is, unless you think about it through an innovative lens, there's an education element that you need to do in a different way to get consumers to understand that there is an ability to access healthcare, quality access or quality healthcare, in the way that you can deliver efficient healthcare in that doesn't compete with the medical scheme market, but certainly solves, from a primary healthcare perspective, solves an enormous problem for the country, and to the point that Mel made and John made, will take a huge amount of pressure off the state, right? And then you add, like I said, the rewards piece, and you can literally open up the value in consumers' wallets to facilitate that.
Ilse, anything you want to add? from the nodding.
Yeah, I mean, it comes to this factor that there's miles and miles of blue sky between the two sets of customer bases. And we are really talking about the bare basics. It is the alternative of going to stand in a queue at a clinic and going back there tomorrow and have lost 2 of my leave days and I only have 10.
I mean, the last point.
It is as simple as that.
Sorry, I interrupted you.
Okay.
No, sorry. The last point I would make is that I think there's also an opportunity that exists, and it's certainly something we're chasing down, to think about health reform in a different way, right? So we often talk about regulations that drive the funding of healthcare, but there are regulations that drive how you deliver healthcare. So, I mean, we have underutilized, I think, clinic sisters in this country that can solve and continue to solve many primary healthcare issues, which from a preventative perspective kind of negate downstream costs. Like, the regulation needs to be supportive of what you can do in that space. And I guess it just depends on your ambitions as a brand into the healthcare sector. But if you're thinking about it as we are from an integrated healthcare perspective, health reform in the way that you think about what certain resources and types of resources can do, and the way that you can build that into product design, and the way that you can build that into how you route someone through healthcare consumption, like, I think there's huge amounts of value unlocked there as well.
Mel, anything you want to add? You good?
Happiness.
Okay. Hands? Anyone? Questions? Be brave, people. Come on. There we go.
Hi, panelists. I just would like to know, what do you feel would be the future of healthcare in South Africa, given the economic uncertainties that we currently face? And going forward in the next 10 to 15, maybe even 20 years, where do we see ourselves on the global platform of healthcare? Thank you.
That's a little
Roy
question.
can answer that one.
That's a little question. I was going to get the first word in because I was going to say that's a little question. Mel's going to give it a go. So you have to give it a go,
In the
Mel.
last round. So it's your turn, Mel.
It's hospital pass. We can't even
Good
tell
dad
you.
joke.
Oh, great day, Joe.
We can't even tell you what's happening in 2 years, never mind in the 10
That is
to
the
15
truth.
years. We just don't know. What I can tell you is, I guess, what we will continue to strive for and lobby for. I think it's absolutely critically important that the regulations in the medical scheme, the medical scheme industry continues. I don't think we can sacrifice that at the altar of NHI, because I think even if NHI pans out, I just want to stress that even in the minister's answering affidavit on the first legal cases, they speak of a full NHI only in 10 to 15 years. So what we're looking at in the interim, if all things fly ahead as expected, you're looking at a primary healthcare-centric NHI. That is it.
You just preempted my next question, sorry, from Sue, that says, this all sounds great, but what happens if the NHI pushes forward and medical schemes fall away? Is this a reality?
Great. So at the same time, let's answer that. So I think in 20 years, you have the same reality where for comprehensive cover, you will still be relying on the private sector. And maybe you're at a situation, and from my lips to God's ears, that we have a robust economy. And to the extent that we have a robust economy, we have a greater fiscus, you've got more people employed, and you are able to contribute more to the NHI, and you can increase benefits. But then I think there'll be increasing, I love the words you guys are using, maybe I'll use it, the benefit stack. So then they...
You're welcome, Mel.
It's a pleasure.
So they would be increasing what's in the primary care benefits, for lack of a better term. So that might increase, but you're still going to be accessing a great portion, I would guess, in the private sector. I really don't believe that there is this desire to get rid of medical schemes. The NHI green paper through to the first versions of the white paper always had the private sector coexisting with the NHI, and somewhere along the line, someone took a pen and decided to go extreme. And I would guess that we will go back to the two existing. And my thought was that would be part of the negotiation as we go into a legal process. That segment of the regulation has already been put on the table for a negotiation, which I thought, whoa, that was pretty soon. I was expecting us to play a little bit harder ball. But yeah, that would be my view. That if either way, we'll have a reality in 15 to 20 years where the two do coexist, even if things are sailing.
Well, just a little backstory. So I remember on the eve of State of the Nation this year, when the report came out that Maropeni Ramakgopa, the minister in the presidency, was saying that the two would continue to coexist going forward, and that deal had been struck at a cabinet lekgotla. And behind the scenes, it was a pretty epic showdown, apparently, between the health minister and the minister in the presidency about that statement being made. So clearly still very much a power struggle about what the future looks like when it comes to NHI. John, for you, what happens hypothetically if the idealistic NHI gets implemented and medical schemes fall away?
I think they can fall away on a basis of policy, but I don't think they can fall away on the basis of market force. And so, to use an extreme example, I mean, the UK has an NHS structure, and they started off with only that as universal care, like state funded, and it was a function of ground zero after World War II. But ultimately, if you look at that market now, it's largely propped up by health insurance products that surround the NHS to give access to care that people need. So I think the principle of providing NHI is sound, as I said at the start, but the reality of the significant amount of moving parts in healthcare means that it is very difficult for the state to take care of everything that people need in the healthcare system. So there will always be place for private sector supply and private sector funding through insurance structures.
Any other questions from the room over here?
Hi, thanks. Is this on?
Yes.
Yeah. I'll direct this to Mel first. I was intrigued by the point that you made earlier on around the shortage of healthcare service providers in the country, and the reluctance of government to allow private sector to drive the production and increase production of healthcare specialists. My question is has the Mandela-Castro bilateral agreement failed us to a degree? Are we finding that, yes, there's an exodus of specialist disciplines out of the country, but in your experience as Netcare, what's happened at a primary healthcare nurse level? I mean, the exodus of these highly sought-after healthcare service providers into markets like the Middle East, Canada, the UK, because we know the government piloted a primary healthcare system for NHI, which collapsed dismally. And so funding aside, and we've got really intelligent actuaries in the room who could probably give us a figure of how short we are in the fiscus for NHI. I want to understand what's happening in the tertiary sector in terms of the provision of just service provider or healthcare service providers. Thank you.
That was very layered. So just in terms of the Cuban program, the reality was 1,000 doctors, plus minus 1,900 doctors that came back, and we struggled to absorb them back into our system just from the ability to pay the salaries. So that was the reality there. And I guess a little bit to the question earlier about can't you just inject CSI? These models have to be sustainable. Whatever you put into place, it's just got to be sustainable. And that wasn't a sustainable model. It's just an injection, in effect. In terms of exodus from our health system, I actually think that that's largely played out over the last decade or two. So we're seeing it at the moment. It's stabilized for a good 10 years, in truth. And currently we're seeing it, but we're seeing it in pockets. I think people that have decided to stay are here and they committed. What we're struggling to see now is rather a systemic failure now of, I guess, all systems and subsystems in the country, just be it municipalities. You are seeing concerns now in the context of medical schools and public systems, academic hospitals to absorb these doctors and fellows and registrars, and we are now engaging to see how is it that private hospitals can step in and provide that support. So we're seeing too many failings at too many levels of the South African system. And, South Africa's always had such a high standard of medical education, right? And it's critically important that we maintain that and we support. So we are working with the deans of the medical schools to see how we continue to support that. We're very worried about that in particular, because that's the future of healthcare in our country.
Any more questions from the floor? Anyone?
Sorry, Mandy, can I just, so untechnical, you know. I think private sector has to realize that we have a role to play. We all must realize by now the government is not going to do it by themselves, whether it's rail, whether it's electricity, whether it's water, whether it's healthcare.
Correct.
We all have a responsibility to help, because if this whole thing collapses, there's nothing left. So in corporate South Africa, stepping in a manner that is sustainable means that we become the credit risk to the service providers. That means my quality of credit means that they can invest. That drives the volume through the systems. And we shouldn't underestimate that responsibility on the private sector. And it's not asking to put money into a black hole. You actually do good by doing this, and you can see the impact on a daily basis.
So
and that should be a very good thing for a private
You look at something like Operation Vulindlela.
Yeah,
it's a
absolutely.
perfect example,
Really
right?
is.
Where you have these 3 work streams where the private sector is helping government, and there's collaboration on logistics, on energy, and on crime and corruption. Why is there no healthcare work stream?
Well, I mean, I'd like to take it a step further. I mean, think of you and your families. They're fundamental pillars of any society, and the fundamental pillars are education, security, and health. So you can't have those compromised, right? So at a very minimum, corporate South Africa has got to be looking at those 3. So you're asking about why there isn't a pillar in healthcare, and trust me, there have been so many dialogues. So the world over, there is this chasm between public and private. There's this notion that healthcare should be for free. And we would all love for healthcare to be for free, right? We would all love it. Who doesn't like everything to be for free? Unfortunately, that isn't the case. So there's a rejection of the help with a desire to go for an NHR where everything can somehow be for free. But when you've got the level of Gini coefficiency, the level of unemployment, it's a pipe dream. It's just a pipe dream.
Is that model possible, though, where we do have an Operation Vulindlela type focus? I suppose this brings me back to the original question I asked, because that would be a completely different model, where it would be the private sector helping the public sector to improve, like we've seen at the parastatals.
Yeah. So we've had 2 presidential health summits that I think have tried to do this. Yeah. I guess this has been the aim. But when you have like worksheets of goals and aims, when you've got however many work streams with however many objectives, you actually know that you're doomed right from the start. You've got to have very targeted projects. You've got to have twinning between hospitals. And, the public sector is large. You started off by saying the public sector, 85%. We tried to do a twinning with Barra some years ago, and Barra was the size of 12 Netcare hospitals. But notwithstanding, we were still very keen. So we could do, and then we partnered Treasury at one stage. We gave them a full audit of all of our systems. How do we do CapEx? How do we do working capital? How do we do HR systems? How do you do replacement of medical equipment? We gave them all of our books, open up. So this is how you're going to run your system. We gave them, we basically did a leadership course for managers of hospitals.
Tell that to the guys at Tembisa Hospital.
Yeah.
Therein lies the problem.
So the thing is called a political will. You've got to have political will.
I mean, I was just going to add to what Mel said. I think you ultimately, simplistically need to have the appetite to facilitate it, right? So, like the best example of collaboration was when we had no choice, and that was during COVID. Like, we collaborated, we delivered a solution that benefited every South African. The only difference there was that there was no choice to have a will.
Yep.
Like, that was the only difference. Mm-hmm. Because from a private sector perspective, what Mel's described, and Mel would be a representative or a proxy for any private sector provider, because everyone is in the same boat. We all have capacity. We all can solve it. Our success as commercial brands within this country lies in the economy growing. Like, it makes sense. There just needs to be an acceptance that there needs to be a will for collaboration.
So I'd like to ask you all a question to wrap up as we near the end here. So I'm going to go from right to left and ask you each just a closing question and some final remarks. So Ilse, for you, what can the business community do today to ensure that the future of healthcare is not only accessible but equitable?
Drive and channel this through union and bargaining councils. Might sound a bit strange, but engagement at union, at bargaining council level, to understand that this is part of decent living. This is required in this country, and if one can get this through those unions uniformly, consistently, equitably, then you've solved a very big part of this primary care and corporates paying for primary access. So we have done a lot of work in trying to set a bargaining council, for instance, in the cleaning industry. Can you believe in this country there's over 2,000 cleaning companies and there's not one single bargaining council?
Sure.
Which means a cleaner, there's legislation around wages, but it doesn't get implemented, short-timed and all those types of things. So we think that here at the basic income level, if you get the unions over the line and consistently pay, that makes a very, very big multiplier impact in this country. And corporates are therefore the funders of this.
Roy, what advice would you give to policymakers, corporates, healthcare providers to create a more inclusive and effective healthcare system?
I mean, simply just to have appetite for collaboration. I think if there was appetite, I mean, you can get technical with all of the work streams that are required and where they've failed and where they haven't, and some successes and pockets of success depending on provincial versus national kind of reform. But the reality is you just need to have appetite. I mean, if there was appetite, it almost changes the mindset in which you go into healthcare delivery. And like I said with COVID, that was a forced mindset. But the answer is such a good indication of something that we can do as a country when we collaborate. So, I mean, it sounds maybe too simple, but I think if that was the case, I mean, the opportunity for deeper penetration of healthcare delivery into South Africa in an efficient way, in a responsible way in terms of how we utilize taxpayers' money would be much better than it is.
Mel, if you could change one thing about the current healthcare system, what would it be?
One thing.
I couldn't find one. I couldn't find one. There are too many. But I must admit the regulations around the medical schemes is a really critical issue, and the state of the medical schools is a big concern. Training of doctors, nurses, and Medical Scheme Act.
John, I'll give you the opportunity to wrap up and close for us.
Thanks, Mandy. Again, very much appreciate everyone's time on the call and to everyone on the panel. We personally, we as Kaelo, just are very excited about the role that corporate South Africa can play and the intellectual property that sits with the intermediary community. We strongly believe that intermediaries are sitting with the intellectual property to help corporates unlock this. There are very different ways of seeing implementation strategies, different ways of funding it. It's not as simple as a compulsory group on an X premium. We've got rewards programs now that shape, the utilization that help fund these programs, and so, that's my take on where we find ourselves is that corporate South Africa sit with unique set of instruments and ability to really unlock access to care like never before. So we're very excited about to take this forward with the intermediaries and corporate South Africa. And so thank you for everyone being involved and to the team who put this together. Also very, very much appreciate it. We hope to do more of this and collaborate, as Roy points out.
Well, I have to tell you that, having spent 90 minutes with you, I'm a big advocate of collaboration. And I speak about this often in every opportunity I get, where we need to see this kind of collaboration between the public and the private sector. We need to see the nexus between business, the public service and us as active citizens as well. And I do think that's the only way that South Africa is going to be better in the future than what it is right now. And having listened to all of you and the private sector standing ready to help, I think there's great possibility there for collaboration going forward. And ultimately, from healthcare providers, from corporate South Africa, insurers as well, I do think that makes perfect sense going forward. We cannot leave it to government alone. Unfortunately, the country has changed substantially. So thank you for being willing to stand up, to seek a solution, and to ensure that there is universal and equitable healthcare for all. I think that's the ultimate goal that we're trying to achieve. So thank you for putting this together, and thank you for all of you who have attended, and best of luck on the journey.
Thank you.
Thanks, everyone.